Welcome, everyone. I'm David Elwood, Dean of the Kennedy School, and welcome to the John F. Kennedy Jr. Forum. I have to say I'm especially happy to see this symbol right over here. When I served in government, I was an assistant secretary in the Department of Health and Human Services, so that feels quite familiar, as does using the term, in this case, Mr. Secretary. Mine was a Madam Secretary. Otherwise, it all feels like home. So I did want to, we're very, very fortunate tonight to have the Secretary of the Department of Health and Human Services, Mike Levitt. And over the past year, we at the Kennedy School have been working on a set of issues that we call acting in time, thinking about the long term. Secretary Levitt is someone who, throughout his career and now at HHS, is focused on some of the longer term issues, the challenges we face, and particularly now around health, where the goal is clearly to improve outcomes and lower costs. And so healthcare clearly fits into an acting in time kind of thing. Now tonight's speaker is interesting. He's a former governor, who did an outstanding job on the Olympics and sought higher office. He's not the only one in that category. Our own governor fits that description. But he was born in Cedar City, Utah. Mike Levitt graduated with a bachelor's degree in economics and business from Southern Utah University. Before he entered public service, he served as president and chief executive officer of the Levitt Group, which was a regional insurance firm, and he established it as one of the top insurance brokers in America. He's also a member of the Utah Board of Regents, overseeing the state's 9 colleges and universities. And in 1992, he was elected the 14th governor of the state of Utah. And during his 11-year term as governor, taxes were reduced, but investments in things like education, infrastructure, and including the interstate highway system was completely revamped and expanded. Here's a remarkable achievement. On 6 different occasions during his tenure, Utah was recognized as one of America's best managed states. Indeed, in 2001, the Government Performance Project, a collaboration between Governing Magazine and the Maxwell School of Citizenship and Public Affairs at Syracuse, said the following: Utah may well be the nation's model in financial management. Growth and debt levels are managed carefully and well. Current year expenditures and revenues are in alignment. Carry-forward balances are earmarked for one-time spending, not future commitments. And 25% of any surplus goes into a rainy day fund, which is protected from frivolous use. During his tenure, he was as governor, Salt Lake City hosted the very successful 2002 Winter Olympics. And from 2003 to 2005, he was head of the Environmental Protection Agency, where he signed the Clean Air Diesel Rule and implemented new, more protective air quality standards. And then in 2005, he was sworn in as Secretary of the Department of Health and Human Services. During his effort, the Secretary has led successful efforts to enroll tens of millions of seniors and disabled persons in the new Medicare prescription drug program. You may recall that many people expected this program to have enormous number of challenges, and it certainly had some. But in fact, by all accounts, I think it has gone quite well. He's also presided over changes in Medicaid statutes, giving more state flexibility, and the reauthorization of the welfare reform bill, now called TANF. So tonight, he's going to talk to us, I believe, about health. This is clearly an area that is near and dear to his heart and fundamental to the future of the nation. So it's my very great honor to welcome him to the Kennedy School, Secretary Michael Levitt. Welcome.
Well, thank you, Dean. And may I just say, this is my kind of place. I'm really pleased to be here. I love to talk public policy. I enjoy interacting with students and serious people who are serious about public policy. I enjoy most interaction on a questions and answers basis, and so I'd like to, if we could, manage our time together. I understand we have about 55 minutes in total. I'd like to take maybe 20 of those minutes and lay out a context for our conversation And then I'd like to turn it over to you. And I feel optimistic that in the next 20 minutes I'll do enough to stir controversy sufficient to engender some comment from you. And we can talk about what I've spoken of. If you'd like to talk about other subjects, I'd be happy to talk about that. Now, I see that several of you are preparing to take a few notes, and so I want to assist in that process. I want to lay out, if I could, 7 very short 2 or 3 word phrases that will become the headlines in your notes. And then I'd like to go back and fill them in some, and then perhaps we can go back and you can make me defend them all, and I'd be happy to. Let's start with the first one if you're in notes. The 3 words are anxiety is warranted. I want to talk about why I think the problems around healthcare are in fact the kind of problem that, if unchecked, could erode our national solvency, and for that matter, it could undermine our prosperity as a country. The next is change in self. I want to talk about the fact that this is not just about changing the system of health care, it's about changing self too. Next phrase, the system, not a sector. I want to challenge fundamentally that we even have a health care system in America today. Next, competition on value. I want to talk about the philosophy that I think needs to be imbued into our system of health care in the future. Every American insured. I want to talk about the way we get to that widely held aspiration that every person in this country be part of the insurance system. Pathway, not goal. I want to talk about where I believe we come together in this debate and where we separate. And lastly, I may go out on a limb tonight and lay out what I think would be the shape of the healthcare insurance system. The phrase is network, not a mainframe. So let's go back and talk some about anxiety is warranted. You can see it and you can feel it everywhere. People are feeling it differently. If you're a worker, you see it in your paycheck. Back in my home state, I met teachers that got a big raise because our economy is good, and yet their take-home pay is lower. Why? Because their health insurance cost went up. I talk to employers every day whose comparative advantage in the marketplace is being eroded because of health care costs. I see doctors and hospitals who are worried about the nature and the business model of their practice. I see economists who are worried. They're worried for a basic reason. I am 56 years old. When I was born in 1951, healthcare was 4% of the gross domestic product. When my son was born, about the time some of you, about 25 years later, it had doubled from 4 to 8. Now, not long ago, we had a little grandbaby. In the time from the time when my son was born until I went into a hospital room and saw my son holding a baby, it had doubled again to 16%. Now, by the time my son becomes my age, it may be 25 or 26% of the entire gross domestic product of the country. And there is not an economy in the world that can sustain a leadership position devoting that much resource to one thing. So people are, in fact, worried, and anxiety is the right response. All right, let's go on to change in self. Now, I need to tell you this is a promise that I've made to myself, that I am not going to talk about this subject without reminding myself and all of you that this isn't just about changing a system. This isn't something we can solve simply by passing a law. It requires not just change in a system, but change in self. Now, what do I mean by that? 10 million children who are considered overweight, that's 1 in 5. Over the last 25 years, we've seen overweight children among the age group of 6 to 12 triple. There are still 46.5 million people in this country who smoke, despite the fact that they know and we know that half of them will either have a disability or premature death as a result. 60% of all adults don't get enough physical activity. We've seen the diabetes rate in this country in recent years triple, or rather go to 70% among the age group 30 to 39. They're getting younger and more intense. This equates to cost. Diabetes alone, healthcare costs of $117 million last year. If you look at obesity, $134 million, direct related costs. Cardiovascular disease, $351 billion. Now you add those up and you begin to see that those diseases alone are a big chunk of the $2 trillion healthcare market. But if you extend it to all diseases that are chronic diseases, it makes up 75%. In other words, those are diseases that can be both prevented or managed. And what I'm suggesting is prevention. Unless we can begin to prevent disease and begin to look at healthcare as being the subject of preventing illness as opposed to just treating it after people are sick, we will not get around that. And the way you do that is we begin to change what goes on inside us. We have to do simple things. We've got to exercise more. We've got to eat better. We've got to get screenings when we are scheduled to get them. So, change in self. System, not a system, but a sector. We talk about the healthcare system, but there's really nothing about the healthcare system that qualifies it to be a system. Now, we're surrounded by systems. Most of you will have a cell phone on your belt. That's a system. We buy minutes from one place and phones from another, but they all fit together. Every one of those vendors uses the same system to optimize the value they provide their customers. They compete on the basis of cost and minutes and service, and can you hear me now? But it's the same system. The airlines, they compete on the basis of rate and time and schedule and service, but they all use the same system to optimize the value that they provide. Banks, I have a blue card, you probably have a red one, we have different banks, but they all use the same system to optimize the value that they provide their customers. Nothing like that in healthcare. Now, the criteria for system, and the way I'm talking about it, is the ability to create competition but optimize value. Now, let me just use a personal example, if I could, on what I think that system should look like, and I want to move on to the next phrase of competition on value. Let me illustrate this by just telling you a personal story. I confess that I'm 56, which meant that it was time for me to get one of those over 50 tests. You know what I'm talking about, Clay. It's the colonoscopy. Now, I had one of these when I turned 50. And all I remember about it is I went to the doctor, I gave him my insurance card, and just sort of sat back to endure the experience. All right? This time, it's different in that in the ensuing 5 or 6 years, first of all, I've become Secretary of Health, and second of all, I bought a health savings account. So I decided I'm going to check around, and I called 2 hospitals and said, I need this procedure. How much will it cost, and when can you see me? Both of them told me, I can't tell you. What do you mean you can't tell me? Well, that's not the way the system works. You need to come in, have the procedure. We'll figure out how much you used, and we'll send your insurance company a bill. Well, that seemed a little unsatisfying to me. So I decided I'm going on a field trip with this. Go back to HHS, and as you know, there are some brilliant physicians there. So I called a group of them together and said, let's organize what you in the business call an episode of care. Now, this is like a little bid sheet on your colonoscopy, all right? So I call a doctor back. I go through each of the different procedures and parts, And the first one is $6,500, and the second one is $5,500. Now, I must tell you, first of all, I am stunned by that cost. I had no idea it was that expensive. Why? Because when I'd done it before, what did I do? I just gave them my insurance card. I was completely disconnected with that transaction. Well, I went home to my wife, who, by the way, also needed to have one, and I said to her, this is serious money. We could be talking about more than $10,000. Maybe we ought to check when we go out to see the grandkids, and maybe it's cheaper out in Utah. So I called, and it was like just under $3,000. A very interesting thing then happened to me. I began thinking, I wonder if there's some difference between the $6,000 one and the $3,000 one. I mean, if you're going to get a colonoscopy, Dean, you don't want to cut any corners, right? So I learned a very important lesson because I realized I was doing exactly what we can't have the system do. I was equating the cost with the quality. I assumed that if $6,000 was different than $3,000, it must be because it's better. Well, what does that set up? It sets up a system that begins to drive on cost, and the higher is the better. You can't constrain costs there. Now, wouldn't it have been a lot better if in that situation I didn't have to come up with my own bid sheet? If there were a set of standard episodes of care that consumers could use? Wouldn't it be a lot better if I didn't have to, if I had some real standard of quality that I could compare them against? Wouldn't it be better if I could know that I didn't have to make a lot of embarrassing phone calls to figure that out? Well, what I've just described to you is competition. Now, a very thoughtful book on this was written by Michael Porter from here at Harvard, referred to as Redefining Healthcare, and the subtitle is Competition Based on Value. I think that's a very thoughtful phrase, and it's exactly the philosophy that I believe our system in the future needs to hold. And what would the characteristics of that system be? Well, first of all, it would be electronically connected. We need to have electronic medical records. Second of all, it would be quality measured so you could compare, and transparency so you'd have standards of quality that were transparent and reported. Third, you'd have episodes of care so you could compare price. And fourth, you'd have incentives where everybody had a motivation to seek out the highest quality and lowest cost. Well, I want to move on to the next, but that's a very important part of what I think the system should look like. Now let's talk about every American insured. Let me say, unless we have every American in that system of competition based on value, the system will still not constrain costs. You ever go to a hotel and you check into the hotel and you close the door and there's a little sign on the back of the door. If you read it closely, it says the charge on this room is like $630 a night. And you think, I can't possibly be paying that. And sure enough, you're not, because in the middle of the night, somebody slips a note under the door that says, this will be $95. It's because somebody negotiated a rate. But if you aren't part of the insurance system, you get charged the back of the door rate. My point is that everyone needs to be in the insurance system. Now, frankly, everyone is talking at this point about the need for everyone to be part of the insurance system, but we tend to use different words when we talk about it. If you're a Democrat, you tend to use the word universal. If you're a Republican, you tend to use the word every. But there is a widely held aspiration that we get to the same place. Now, I want to get back to this, but I think it is vital in terms of our discussion today that we acknowledge that for a system to work, we do ultimately need to get everybody into the system so that we can begin to manage healthcare in a more thoughtful way. Well, let's talk about the last one, and that is a network, not a mainframe. Many of you will not remember mainframe computers. They were these big, bulky, gigantic computers that could fill this room, and they were invented in the 1960s and the 1970s. They were bureaucratic in that you had to order up who could use them. It could really only process one thing at a time. Everybody had to do things in basically the same way. Since the early 60s and 70s, the world has begun to change. It has begun to intuitively organize itself into networks. You see this everywhere. Our world revolves now around networks. It's the way we communicate, it's the way we buy, it's the way we interrelate. Commerce has begun to organize itself into networks. Nations have begun to organize themselves into networks. We're now fighting a war with a networked enemy, the war on terror. We started off fighting that war with a mainframe army, but very quickly realized that you can't defeat a networked enemy with a mainframe army. You've got to fight a network with a network, because a network will always beat a mainframe. Now, I bring that up because I believe Medicare and many of our other large socialized health insurance systems were created in the 1960s and 70s, and they were created on a mainframe model. Now, I skipped over and didn't mean to. I want to go back to the whole idea of pathway, or not the goal. I mentioned the fact that there is, in fact, I think, an agreement on the goal of getting everyone in. That isn't the disagreement. The difference is, how do we go about it? There are widely different views on what government's role should be in organizing this system. Many believe that government ought to be the owner of the system, that the government ought to set the rates, government ought to make the plan decisions, government ought to make the consumer choices, and government ought to raise taxes and pay for all of it. It looks a lot like the national defense system. Other people believe that the government has a very clear role, but it is to organize a system. That is to say, you set the rules, you eliminate inequities and unfairness, and you subsidize the poor. Those are the two basic differences in the approach. So as we approach this system, I believe that a network needs to be established, not a mainframe, and that the mainframe basically represents those who would have the government own the system, and a network would be those who would have the government organize the system. Now, the time I committed to stimulate conversation is about up, but I suspect one of you will ask me the question as to how I see that network shaping up, and I want to commit to you that I'm prepared to answer that in some specificity if you're interested. So with that, Dean, I'm ready to jump into a big discussion. Should we just start, or?
Let me just set it up.
All right.
Thank you very much.
Thank you.
As is our typical plan here at the Kennedy School, we have microphones located in 4 locations. One is right here, one is up there, one is there, and one is there. And just a couple of ground rules. Questions here, good questions, have 3 characteristics. Number 1, they involve introducing yourself. Number 2, they are short and involve only one thought. And number 3, they end with a question mark. So with those ground rules, please identify yourself, and we'll begin right over here.
Hi, Secretary Levitt. Welcome to the Kennedy School.
Thank you.
My name is Neil, and I'm a medical student, and I'm also a student here at the Kennedy School. I was interested in the relationship between 2 of the topic areas that you described. In one, you issued a challenge for us to change ourselves. And in doing so, you mentioned several of the statistics that I'm familiar with from a medical background, namely the obesity epidemic, the fact that so many folks still smoke even though they know it's not a good idea. You also mentioned the idea of leveraging the market to improve quality through competition. My question to you is, a lot of the statistics that you mentioned and my own anecdotal experiences suggest to me that people don't make rational decisions about healthcare. Given that, how do you see the marketplace still ensuring quality?
Well, let me say that I think the best enforcer of quality is the marketplace. I'm involved deeply right now in import and food safety. safety equated in this case to quality. I've been at seaports and post offices because of the border entries. The president's given me assignment to come up with a strategy. What's become more and more evident to me is that the world enforces quickly and harshly anyone who does not produce safe, quality products. But in healthcare, where we ultimately miss is that people don't know the quality because there is no measure. And so in order to have a system of competition based on value, we have to know in a transparent way, according to a standard that we all accept and agree, a couple of important components. One is the cost in a way that we can compare, and the second is the quality based on a standard we've agreed upon. Now, who sets the standard of quality? In my mind, it has to be the medical profession, because it wouldn't matter if the Secretary of Health or the Assistant Secretary for Public Health set the standard. If the person's family doctor said, I don't believe that standard, they'll believe the doctor. So the medical community has to develop those standards, and then we have to have transparency. Now, I believe what we'll end up seeing when we have electronic medical records in a way that will provide sufficient adoption that we get quality data, I think you'll end up seeing the health equivalent of Travelocity. I think we'll also, or the health equivalent of Quicken, where we're able to get information that begins to populate health accounts that we own and hold that will begin to provide that quality information and give us access to the transparent data that allows us to make quality decisions. The reason people don't make quality decisions now is because they don't have the information, and that has to change.
Right up here.
My name's Clifford Marks. I'm a sophomore at the college, and my question's about the Congressional Democrats' CHIP expansion plan. What do you think the president should do when that gets to his desk, and doesn't that plan help fulfill the government goal you outlined of subsidizing health care for the poor?
Very good question, very timely question. I suspect the House of Representatives is voting as we speak on that bill. SCHIP is a very important program. It's a very important part of the way we meet the obligation I've spoken of, which is for government to assist the poor, the elderly, the disabled. But it was focused on those that were poor, not as the vehicle by which we would expand health care to every American. Currently, SCHIP has an eligibility of 200% of the poverty level, which is about $42,000 for a family of four. This bill would allow a person to be eligible as much as $83,000. Now, someone in Washington pointed out to me that if you make $83,000 a year, in most situations you qualify for the AMT, or the alternative minimum tax, which is a tax on rich people to make certain they pay their share. Only in Washington could you be rich and poor at the same time. Qualify to pay a rich person's tax and at the same time be eligible for SCHIP. Now, the proponents indicate that it will add 4 million people to the rolls of the insured. Let me break that down for you. Of the 4 million people, 1.2 million of them are already qualified for Medicaid and simply need to sign up. They are anticipated new Medicaid recipients. No new eligibility there because all we have to do is enroll them. Now that leaves you, then you take 900,000 of the remainder, and they're already eligible for SCHIP. So you've got SCHIP eligibles in the plan, you've got Medicaid eligibles. That leaves 1.9 million people. Now, who are they? The 1.9 million are made up of people who make above 200% of the poverty level. What do we know about them? Well, one thing we know is that if you're in a family that makes more than 200% of the poverty level, that 75% already have private insurance. We know if they make more than 300%, that 90% already have private insurance. So of those in the 4 million who are currently not eligible for a government plan, more than 75% of them already have private insurance, and this bill will motivate them to cancel their private insurance and go where? To the government-run healthcare system. This bill ought to be reauthorized, or SCHIP ought to be reauthorized, but we ought to reauthorize it in a way that focuses on its intended purpose, and that is to pay for insurance for low-income children. It ought to be taking uninsured children and getting them into the private insurance system, not taking people who are already in the private insurance system and moving them into government insurance. Now, we can solve this problem, but we've got to get down to determining how many people truly in that category are under that level, reauthorize it, and find them, do the hard work of finding them. And it's a very important topic and one that I think highlights the debate about what kind of a healthcare system and what is the role of the federal government. Is it to own the system or is it to organize the system? Good question.
Right up here.
Hi, thank you very much for coming. My name is Don Kurth. I'm an academic physician from California here as a student at the Kennedy School. My question relates to the pharmaceutical industry. The pharmaceutical industry is spending $200 million a month lobbying our elected legislators. In April of this year, the Senate Finance Committee produced a scathing report against the corruption in the pharmaceutical industry, kickbacks and whatnot. What's the government doing to get this under control?
Let me say that no one can endorse or tolerate corruption at any level. What I believe is that, first of all, if laws are broken, they need to be enforced. But the most efficient enforcement is an efficient market. And if we had a marketplace in the pharmaceutical business, we would begin to see improvement in the quality and diminishing in the cost. Now, how do I make that statement? Let me point out that the dean talked about Medicare Part D. This was among the most remarkable events in healthcare in half a century. We had for a long time been saying we need to have a prescription drug benefit for seniors. But it had over and over been produced as a big addition to Medicare with a one-size-fits-all government program where everybody gets the same plan. Instead of doing that, we concluded we'll experiment now with something brand new. We're going to create a market. And we're going to allow many people to produce plans, and we'll have them compete. Well, people said people aren't going to sign up. They're not going to make a choice about plans. Well, we are now 18 months, almost 2 years into it, and 93% of those who are eligible have enrolled. Medicaid, which is health care for the poor, we've been at that 45, almost 50 years now, and we still have 50% who are eligible who haven't signed up. People said they won't be happy with a plan. Over 80% are happy. People have said the cost won't go down. We started at $37 a month. This year we'll deliver it for $22. Why? Because we engaged the market and let consumers make decisions, and people have enrolled, they're happy with their plan, and the cost is going down. Now, that's competition based on value. That's a system where people have a managed care environment and a choice. And when that happens, quality goes up and cost goes down. And the same thing has to apply in any case. That kind of a market will squeeze inefficiency out.
Right over here.
Shaloha. My name is Ari Cole, and I'm an internal medicine hospitalist physician here in Martha's Vineyard in Massachusetts and Hawaii. I want to thank you very much, Mr. Secretary, for your service to our country and to our president. My question is a very controversial one. It's based on steroid-poisoned America. I travel a lot for business around the world, in Australia and in Europe. And in some of those countries, or if not all countries in Europe, mandate that steroids not be used in cattle, poultry, and milk and cheese products, by injecting animals with steroids, which secondarily come into our body systems through milk and cheese and beef and poultry. I support the food industry completely. They do a great job. My question to you is, how can we, find a happy balance in not poisoning America secondarily through steroids from our food sources in beef and poultry and eggs and cheese and milk, which causes hypertension and obesity and diabetes and stroke and increased health costs. How do you feel about steroid poisoned America, possibly?
I wish I were technically competent to answer that question. I'm not. I don't know the medical, I do not have a medical foundation to respond to it medically. I will tell you this, that food safety has been a topic of great public discussion and a big topic of interest to me as a result of the assignment the President gave me. And may I tell you that more and more of our food is in fact being imported from outside the country. It is a fundamental change in the way our markets are beginning to work. And that we have been extraordinarily blessed, I think, in this country to have a system of food safety that has been effective. But as more of our food comes into the country, we're going to have to change the way we think about what we eat and where it comes from, and begin to create a system that contemplates a high amount of it coming in. We can talk more about it, but to be just frank, I'm not able to answer your question, and I don't have an opinion on the steroid issue.
All right, right over here.
Good evening. My name is Tom Gill. I'm a first-year student in the Master of Public Policy program here. Looking ahead to the 2008 election, who do you think, which presidential candidate do you feel will best champion the cause of health care?
I have, as a member of the President's Cabinet, not begun to be deeply involved in it. I know most of the presidential candidates. I've worked with several of them. I've worked with the governor of Massachusetts, former Governor Romney, in the development of the Massachusetts plan. I have a high regard for that. I also have a high, we work together on the Olympics, as was mentioned. But I have not been involved, and I will tell you, rather than try to define a particular candidate, let me tell you what I think you can look for. I think you'll see everybody putting forward a health care plan, but I think you very quickly be able to see that there is a fundamental difference in philosophy. It's the difference I talked about before. Some will choose to treat health care like the national defense system, where the government owns it, operates it, sets the prices, defines the plan, raises the taxes to pay for it. They view government's role as being organizing, or rather as in owning the system. You will see others that begin to believe that you can organize a market that will be efficient, that will give people choices, and that consumers ought to have more choices. That will be a basic difference, and you can essentially look at the two plans from that standpoint. My own view is we do need to solve this problem, and that the 2008 election is an important year to highlight it. And I can go into more detail about what I think the plan ought to be, but I probably will stop there in terms of the politics of it.
Right over here.
Hi, Secretary Leavitt. Thank you for coming. My name is Cecilia Gerard. I'm a student at the School of Public Health here at Harvard. My question is in regards to the uninsured population. There's an estimated 47 million Americans without health insurance. That's about 1 in 10. On top of that, there are several million uninsured guest workers and illegal immigrants here in the United States who also need care while they're here. Could you please speak to whether this subgroup of the uninsured is considered within your tenet every person insured? And thank you.
I'm going to accept that as a question about, so how would you solve this problem? Let me define for you what I indicated. I think this ought to look like a network. I indicated that I thought there were some characteristics of the system. I'd like to be just a little more specific about it and how it could and should unfold. First, as I indicated to you, I believe we need to have this needs to be a national goal that will come about, I believe, through the 2008 election. Second, I think we need to develop a strategy. And the strategy, quite clearly, in my mind, ought to have at least 5 components, The first component is the statement I made before. If you are elderly or poor or disabled, if you are a person who is in hardship, the government needs to provide you and offer you insurance and needs to pay for most of it. That's what we do with Medicaid, Medicare, and SCHIP. Those programs need to be well-focused to meet their purpose. Second, I believe every American deserves to live in a state where the market has been organized in a way that assures that every person has an opportunity to acquire an insurance policy that is consistent with their needs and philosophies and that is affordable to them. Third, I believe that if a person still can't afford a policy, and if they aren't eligible for the programs I've spoken of, then it's a rational thing for the government, the state and federal government in combination, to subsidize their purchase of a private insurance policy. Fourth, I think it is unthinkably wrong for our country to provide the biggest deduction or tax benefit that we give in the entire tax code to part of our population because they buy insurance through an employer and completely ignore those that have to buy it on their own. And that's what happens. If you are a teacher's aide who doesn't work enough hours at the school district that you qualify for benefits, and you're married to a person that works as a contractor but doesn't have insurance or a small business, you can buy insurance, but you have to buy it in the individual market and you have to buy it after you pay your taxes. It is a huge disadvantage, and it's too big a lift for most people. We need to solve that. Now, the President's made proposals to solve it. Others have as well, which would take different approaches but would level the playing field on the tax benefit. People don't fully recognize this, but it is the most significant subsidy that we make as a government to anyone for any reason, let alone health care. We need to fix that. And if we do, it will have a profound impact on the number of people that will buy insurance. The Lewin Group, a very respected organization, recently looked at these proposals and said that if they were enacted, as many as 20 million additional Americans would buy insurance. Now, to do that, some things would have to happen in the marketplace. So let me talk some about what I think the role of the state would be. I've indicated I think this ought to look like a network. I think that our founding fathers may have established a form of government that is perfect for a networked age. States each need to organize their market in a way that will assure that every person can get access. To do that, the federal government may need to set deadlines on the states and say, you need to solve this problem in your own way by a certain date. If they do, and you combine that with a solution to the tax problem, I think we can in fact get to the point where every American has access to insurance. Now, you ask about those who are here and are not citizens. That's the fifth point. There needs to be a safety net in our society for those who need health care. But this really gets into a much larger question of immigration. That's not my expertise, and I don't suspect we'll spend much time on it tonight. We spend a lot of money on that today, but there needs to be some way of accommodating it. But for right now, we'd be a lot better off making certain that people have insurance who are here legally and deal with the issue of those who are here undocumented with our safety net.
Right up here.
My name is Charles. I'm a student at the college here. Thank you, Mr. Secretary, for speaking today and for taking questions as well from us. My question has to do with your second point, change in self. You talked about the need for Americans to make individual changes like exercising more, eating healthy, things like that. And a lot of times, Americans' ability to do that is not necessarily entirely in their own hands. It depends on things like whether they're employed, whether they live in an area where these things are affordable. And a lot of times that maybe is administered by other departments. What, if any, are the ways in which HHS works with departments like the Department of Labor, Housing and Urban Development to administer and recommend policy in the way that has the greatest benefit for citizens?
Actually, the Department of Health and Human Services manages the vast majority of our human service programs at the federal level. All of our welfare programs, child protection, and so forth come through the Department of Health and Human Services. But a very important principle here is that we represent the federal government in a partnership with the state governments. Almost all of our human service programs are managed at the state level. Why? It's because they live among them. They are there. They have the mechanism to do it. The federal government does not. Now, I'd like to use that as a moment to say, why is health care different than that? The states are best able to manage health care as well as other human service programs because they have the mechanism already in place to do it. Now, you asked me how we interact with them. I had a really interesting conversation with Roger Porter, who is an acquaintance of mine who teaches here at the Kennedy School, about the interagency process of coordinating federal policy. And I don't know if you're asking me about that or not. If you are, I'd be happy to respond. But let me just say that most of the correlation of those programs doesn't happen among departments of the federal government. It happens between the federal government and the state governments because they have demonstrated over time a far greater capacity to deal with the delivery of human services than the federal government, which is mostly about policy and collecting money and splitting it up in ways that sometimes mystify others.
Thank you.
Right over here.
Hi, my name is Alex Alexander. I am a mid-career student here. Mr. Secretary, my question is relating to electronic medical records. And perhaps we all understand that this is probably the single most thing that can bring about radical changes.
It is.
And this is even called for a presidential mandate to have an electronic medical record by 2014. Considering the progress thus far, do you think that date is a realistic one? And part two of my question is relating to, because I worked in this field for some time and felt that a couple of things which are huge challenges are funding and the expertise. So would you consider probably an organized framework of something like a public-private partnership to speed up the process?
This is a subject that we could spend a long time on, and it's an area on which I have considerable passion. And so I'm going to constrain myself to some rather general subjects, and perhaps at another time we can get deeper. For those of you who don't follow this as closely, let me just lay the framework. It is a widely held belief that we could dramatically streamline the practice of medicine and our own interaction with it if it happened like it does in any of the other networks or any of the other systems that I referred to earlier. But 85% of all medical records are still paper. The way the practice works is not consistent with virtually any other part of our modern world. Why? Well, there are many reasons, but one of the most challenging is best reflected when you look back at railroads. I've spent a lot of time studying railroads because in the early 1850s, we started to build railroads. We built them in the north and the south and the east and the west, but there was only one problem. They began to build railroads with different rail gauges. That's the difference in how wide the rails are. So it took almost 30 years to get people to redeploy their track in a way that the rails lined up. Essentially, that's the problem we have with electronic medical records, is that a lot of people have started to develop computerized ways of doing things, but they haven't had the rails line up and they don't have computer standards. So there are basically two challenges. The first is to get the rail gauges to line up so that the records can talk to each other. And secondly, to get those who are in the medical practice to adopt medical records as a method of practice. Now, there's a big disconnect here because when we asked physicians to invest in electronic medical records, they logically say, why? Am I going to make more money? Am I going to in some way have my investment repaid? The problem is that the benefit in our current financing system inures to those who use the system, meaning payers and patients, not the doctors. So we're going to have to go through a quite dramatic macroeconomic change in the medical practice. Now, I will tell you that we're fast making progress on the standards. We now have a certification process in place so when people buy a system, they can know whether or not it is moving toward this interoperability. We also have the ability, and we're making progress in ways that we can begin to connect the payment system. this is where I need to stop because I'll get beyond what most of your interest is. But suffice to say, I believe we can meet it by 2014. But I want to tell you what I think the future looks like. We think about electronic medical records, and it's different things to different people. If you're a physician, you're thinking about a clinical record. You're thinking about how I can keep my patient records there. However, if you're a patient, you're thinking about something entirely different than that. It's the conversation I had with a woman in my office who said she had to take her twins to the doctor. She said, I have to be gone tomorrow. When she returned, I said, how did it go? She said, it went fine, but I spent half the day being a medical courier, going to doctor's office, picking up big brown envelopes to take it over to a physician who could interpret it. Wouldn't it have been a lot better if there was a way in which I could email those reports? Well, it doesn't exist in the context of today because the rail gauges don't line up. So patients will be looking for ways in which they can use these to their advantage. Clinicians will look at it in a different way, and I've got a lot more I could say about that, but I think our time is getting close.
Do you have time for another question,
I
or do you
do.
need to run?
I
All right,
do.
so this will have to be the last question.
Thank you for being here, Secretary Leavitt. I'm Josie Hahn, and I'm a doctoral student at the School of Public Health. And my question is, in regards to most of the topics that you brought up, obesity, diabetes, and a number more, they have stark disparities based on race, class, and gender. In the communities that I've worked with in Harlem and the South Bronx, they make very rational decisions individually and as communities, but the resources definitely aren't present. As a very responsive and effective state politician and on the federal level, what's the best community mobilization mechanisms that you suggest? And also, how do communities get in touch with you?
Well, first of all, let me say I think that most of these are individual decisions that have to be made, and it's changes not just in our brain, it's also changes in a desire that we make. So I'm not 100% sure I know what you mean by when you say the resources aren't available. Do you want to elaborate a little bit?
Absolutely. I would say that feeding a family, where fruits and vegetables are either in terrible condition or not even available in most of these communities that are low income and minority, doesn't afford for a nutritious diet. Nor do children's programs that have tons of advertising, targeted towards, very unhealthy, just being an example of like poor quality products flooding a market. So I don't think that these selves or individuals are per se making bad decisions based on, like irrational thoughts, basically.
Well,
I think
this is a really interesting question. I wish we had time to discuss it more, but let me just acknowledge that I think this is another case where we have to decide what the role of government is. Is it the role of government to own or to organize? Do we use compulsion or do we use markets in which to drive it? Now, my own view is that in any area of America, if there is, particularly an area like food, where if a person doesn't have enough food, we give them food stamps because we want them to have nourishment. We want them to have enough and good food, that we can solve that. I'm not going to satisfy you because the time doesn't allow it, and I'm disappointed at that because I think it's a very thoughtful question. But as to how you can get a hold of me, you could send me an email at ml.05@hhs.gov. That's ml.05@hhs.gov. Could I just, Dean, close up tonight by kind of reviewing what I have said? I think we've talked about the fact that there is a reasoned anxiety about the healthcare system because it is fundamentally broken, and it needs not the quality of the care so much that we receive, but the way we finance it. And in fact, it is, in my judgment, the kind of problem that we have to fix because if left unchecked, it's the kind of thing that could fundamentally undermine the prosperity of our country. We've talked about the need for prevention to be an important part and that it's a vital national interest to sponsor that, but ultimately it comes down to the fact that when you change your heart, you change our nation, and that all of us have an individual responsibility to make that happen. We've talked about the fact that our healthcare sector is large, rapidly growing and expanding, but in fact we need to mold it over the next 10 years into a sector. We've talked about the fact that that sector, or that system needs to have a philosophy, and that in my judgment, competition drives quality up and cost down. And that to the extent that we can provide transparent information to consumers, they will make choices that will improve their health care and drive costs down. We've talked about the fact that every American needs to be part of the insurance system. We've talked about the fact that there is a shared goal there, but we now have to reconcile our different values. And my belief that in order to solve this, we have to create a network, not a mainframe. Now, I do want to say this. What I've said about this being the most challenging problem we face as a country, domestically, I believe. If we don't solve this problem over the course of the next several years, it will begin to overrun everything else we do. One program that I manage, Medicare, is 3.2% of the entire gross domestic product of this country. It is now 45% of it. For the first time, we've crossed a threshold where more than 45% of that entire program is now being taken from general tax dollars, not trust fund dollars, not money we pay in as a matter of payroll taxes, general tax dollars, which means that higher education, that research and development, that any other part of what government pays is being now diminished because of this problem. We live in a global marketplace. It's a rapidly changing place where we have to be competitive in ways we have never been challenged before. And I just want to leave you with this. When it comes to a global marketplace and change, there are three ways we can respond. The first is we can fight it and die. The second is we could accept it, and I believe we would survive. Or last, and I believe best, we could lead it and prosper. This nation, for 230 plus years, has prospered because we have led. This problem, I believe, is this generation's dilemma to resolve, to determine whether or not that prosperity and that leadership will continue. I believe it can, I believe that it will, but I believe we all have to work together in a way that will produce better health at lower costs for all Americans. Thank you.
Thank you, Mr. Secretary. You're welcome back here at the Kennedy School anytime, and all of you have a safe evening. Thank you for coming.